going to get started. Hopefully more people will come in as we move along. This is the top paper session, and I'm sure you understand the rules. The person will present, and then we'll ask questions, and then we get to vote on the quality of the papers presented. I'm Scott Shakora, and I'm chairing this session along with my two moderators, Professor Michelle Sudin, Professor Skara. So I think we'll get started right away. And the first paper is on diff and auto pSWE accurately assesses liver steatosis, fibrous risk in patients affected by obesity with Maslid, a prospective head-to-head biopsy-controlled study. And, I'm sorry, it's being presented by Dr. Larissa Nixdorf.
So, good morning. I do see my presentation here on the screen, but not on the big one. Okay, perfect. My name is Larissa Nixdorf, and I'm working at the Medical University of Vienna as a resident at the Department of General Surgery. And I'm really happy to present you our work regarding the non-invasive liver assessment in patients with obesity and liver disease. I have nothing to disclose, and at first I wanted to tell you why this is so important for us and for our patients. So we all know that muscle D is a big and growing problem and a global threat, like the epidemic of obesity and diabetes. You know that muscle D can lead to liver disease like liver cirrhosis, and for example in the US it is the #1 cause of liver cirrhosis and indication for liver transplantation already. On this slide I wanted to show you that the problem is not new at all, and also we are not at the end. So in 2018 Estes et al. Developed a model where they showed the disease burden and the development of the disease burden from 2016 to 2030. And you see they looked at it at different parts of the world. So China, there are different countries in Europe and also the US, and they predicted a steep increase of the prevalence of muscle D. And when you look at the numbers that we have right now, then you have to admit that they were not wrong. In fact, they underestimated it for some parts of the world. The next problem with muscle D is the diagnosis of it. Currently, we have different ways to diagnose muscle D and other liver diseases. So we have the liver biopsy, which is the gold standard, and the MRI as imaging method. You could also give contrast agents to gain some information about the liver function. We have fibrosis scores where you use patient characteristics or laboratory results to calculate the liver function. And then we have special developed methods like the FibroScan where you can measure the liver stiffness to assess muscle D. The problem with all these ways are that they are either invasive when you think of the liver biopsy. They're expensive or not feasible when you think of the MRI. Not every hospital has an MRI, and if you have one, you do know that for months there are no appointments. The fibrosis scores and the FibroScan, especially in patients with obesity, can also not be accurate. So it's clear that the ambition to develop new ways of assessing the liver health or muscle D are high. And so the RFI-based methods, so acoustic radiation force impulse-based methods, point shear wave elastography and ultrasound-derived fat fraction were developed. And this will be the topic of this talk because these newly developed methods are compared to the ones that we already know. So we already know the FibroScan. This is based on vibration-controlled transient elastography to assess the liver stiffness. and the controlled attenuation parameter, where you can measure the attenuation of your ultrasound signal, the ultrasound wave, to assess steatosis. Here is a picture of an FibroScan exam. So you do have the probe that you position on the skin over the liver, and a mechanical impulse is generated, and the probe will measure the answer of the tissue that you're measuring. And you will send ultrasound waves to the liver tissue and then measure the attenuation of it, and this will give you an answer or an idea of the fat content the liver has. Methods are the point. So this method is an ultrasound-based method. So you always have a picture of your liver in the ultrasound. We'll send ultrasound waves and then measure the shear waves that are generated from the tissue. The UDFF is also ultrasound-based. You will send ultrasound waves into the tissue and then measure different answers of the tissue, like the speed of the ultrasound waves, the attenuation of the ultrasound waves, or the distribution. On this table, you see both methods in comparison to each other. And like I said, the fibrosis measurement is based on the measurement of shear waves. On the right side, you see the FibroScan-based methods, so shear waves generated via mechanical vibration. On the left side, the ones that were newly developed, and there you measure the shear waves generated by acoustic impulses. The steatosis measurements is based on ultrasound in both ways. And in the FibroScan, you measure the attenuation of the ultrasound waves, and in the United-derived fat fraction, you measure speed, contribution, and attenuation. And then you will have a result like in percentage, like the percentage of fat the liver contains. These newly developed methods could have some advantages. At first, we do have the ultrasound image of the liver, so you can choose your area of interest. You can choose an area where you think, okay, this is representative for all of the liver. You don't have that in FibroScan. In FibroScan, you do all your measurements blind. This could lead to a better outcome in obesity, so less false results. And you can integrate this whole exam into your routine ultrasound exam. In our work, we looked at 134 patients. All of them had obesity, all of them had bariatric surgery, and during the bariatric surgery, liver biopsy was taken. All of them had liver disease, and then we measured the muscle D with the non-invasive methods that I just told you about. Our patients had a mean age of 43 years and a mean BMI of 43, and most of them were female. Like I said, all of them had liver disease, and the vast majority due to metabolic-associated factors. So at first, we have a look at the performance of our non-invasive measurements compared to the biopsy. And as you can see at the first glance, that the methods performed best in advanced fibrosis or cirrhosis, or in the mild steatosis. So you could say that in the extremes of the liver disease, the non-invasive measurements worked best. The mission of our work was to see if the newly developed methods are equal to the ones that we already have, to the FibroScan. And on the left side, you see the methods for the liver fibrosis measurement, and we had moderate correlation between the two methods, between the vibration-controlled transient elastography and the auto-point shear wave elastography. On the right side, you see the one for the liver steatosis, so the ultrasound-derived fat fraction compared to the controlled attenuation parameter, and here we had a strong correlation between these two methods. Now we take a look at the performance of it in the fibrosis assessment. And on the left side, you see the auto-point shear wave elastography compared to the liver biopsy. And on the right side, the vibration-controlled transient elastography compared to the biopsy. We did not find any statistical difference between the auto-point shear wave elastography and the vibration-controlled transient elastography. And more importantly, one measurement of the auto-point shear wave was equal to 5 measurements of the vibration-controlled transient elastography. The same goes for the steatosis assessment. Also on the left side, you have the newly developed ultrasound-derived fat fraction. On the right side, the controlled attenuation parameter. And also here, there were no statistical significant differences in the accuracy between those two non-invasive methods compared to the biopsy. And also here, one ultrasound-derived fat fraction acquisition was equal to 5 measurements of the controlled attenuation parameter. To sum it all up, muscle D is a big problem and still growing and affects all of our patients. The assessment of fibrosis, or the non-invasive assessment of fibrosis, is more accurate than the one of the steatosis. The acoustic radiation force impulse-based methods are safe, easy, and fast, so these are the newly developed ones. We had no differences in the accuracy of point shear wave elastography and VCTE, or ultrasound-derived fat fraction and CAP. But the newly developed methods, the point shear wave elastography and ultrasound-derived fat fraction, are faster, and they can be included in your routine workup, so in every ultrasound exam that you do with your patients. So I want to thank you for your attention. Thank you for including me in this session, and my team for the support.
Thank you very much. Nice presentation. Can you tell us a little bit about the cost of this machinery?
Yes.
If I understand well, it's a module you can add to a normal ultrasound machine as opposed to a specific tool. Is that right?
So there are different ultrasound machines where you can include these 2 software programs. So you can include the measurement of the liver stiffness, so the auto-point shear wave into it, and separately also the measurement of the ultrasound-derived fat fraction. The actual cost of it, I have to say, I don't know. Yeah, but you can include it when you will buy a new ultrasound machine. Then I think the cost of the extra software might be bearable.
Thank you. Any questions from the floor?
Thank you very much.
Yeah. Do you want to introduce me?
Our next speaker, Dr. Joel Pujola from Spain. Could you please start?
The topic of this presentation is indications and coverage of pediatric metabolic bariatric surgery, a worldwide, if so, survey comparing different national guidelines. And it will be presented by Dr. Juan Pilo Ravai.
So thank you very much, dear friends. It's a pleasure to be here with you and having chosen this paper as one of the top papers of the Congress. So you know that the prevalence of obesity in children and adolescents is quite worrisome, and projections indicate a continuous rise, so it's getting worse. We also know that while lifestyle modifications must be considered the first-line approach, their efficacy is often modest and not durable. And that's why metabolic bariatric surgery has consolidated as a therapeutical option for pediatric patients with obesity who do not achieve satisfactory weight loss with conservative treatment. So finally, over the last few years, many different supranational societies have widened their recommendations for pediatric metabolic bariatric surgery. If we focus on the two main largest surgical societies on the field, the American one and the International Federation, they recommend considering surgery if BMI in these young people, if BMI is over 40, or which is the same over 140% of the 95th percentile, or even lower if they have a BMI below over 35, if there's any obesity-related comorbid conditions. To be noted, they do not consider any age limit as a prerequisite for surgery, as scientific evidence today seems to support that surgery does not negatively impact pubertal development. So it's not that important, and the sooner we operate, the better, and the more chances we have to get acceptable outcomes. This is the international recommendations, right? However, due to the large number of national societies that make up our federation and with their diverse socioeconomic and cultural context, national level indications may not fully adhere to these recommendations and even could vary from one country to another. And that's why IFSO decided to analyze which are the real-world indications at a national level for this pediatric population. And at the same time, it was decided to analyze, to assess whether the costs of the procedure are covered by any means in each country, either by public health service or any insurance company. So this is the aim of the study. And so we decided to make a survey consisting of some questions that were afterwards emailed by IFSO secretary to the 76 different countries that make up the federation from all around the world. And what I'm gonna present here is a part of the results. To begin with, we realized that the response rate was 90%, and this gives power to our results. In fact, the only 10 countries that did not respond were countries that perform very few procedures per year if we compare with the whole procedures that are made worldwide. 76% of the countries were discovered to have guidelines where they include some indications and recommendations regarding children and adolescents' metabolic surgery. And of those, and contrary to the international recommendations, more than 1/3 of them set a minimum level of physical development before considering these young people for surgery. Based on age, they have to be older than 12, 13, 14, 15, 16 years old, or based on clinical classification of the children or adolescents. They have to have a Tanner stage at 4 or 5, which means nearly fully developed or adults. We also discovered that BMI, although being starting controversy today, is still a commonly used parameter to indicate surgery and is typically used as a threshold for eligibility. But here also, the indications varied across countries. Whereas some countries, yes, they follow the international recommendations, others did not. And especially there are some countries, 14% of the countries that recommend surgery, but only for those people who have a higher BMI, BMI over 40 or 40 with comorbidities, or even 50. And finally, there's 8% of the countries, such as UK, the Netherlands, South Korea, or Italy, that recommend not to perform surgery in these adolescents or young people. Some of the guidelines recommend some techniques to be used in these young people. And in these guidelines, most of them recommend to perform sleeve gastrectomy, 60% of the cases, And 42% of the cases recommend to perform sleeve gastrectomy or standard room-wide gastric bypass. To be noted, none of them recommend to perform hypoabsorptive procedures in this young population. In fact, some countries underline not to perform hypoabsorptive procedures, probably because they have a long life expectancy, and we can have problems at the long term with those guys. Well, we know that surgery today is safer and more effective, but the performance of a correct surgical procedure requires complex technique, complex structure, so sometimes is economically hard to accomplish. So we asked for it as well, and we discovered that 60% of the countries offer some form of coverage for pediatric metabolic bariatric surgery. In 50% of them, it was covered by the public health service directly, but private health insurance companies also could cover pediatric surgery in 21% of the countries. In fact, in 9% of these, coverage is available exclusively through private insurance companies. And what is quite worrisome is that there's still 40% of the countries that do not offer any coverage at all for these procedures for people in need. And here we found some differences depending on where the country is located. Higher coverage was found in those countries in North America, Asia Pacific, and Europe, with more than 80% of the countries with coverage, 85%, whereas the lowest coverage was found in Latin America, where surgery is covered only in 31% of their countries. So I'm finishing, but the take-home message should be that pediatric bariatric surgery practices remain highly inconsistent worldwide, with major disparities in eligibility, criteria, and access to care. So a unified, evidence-based approach led by IFSO and other professional societies, in my opinion, is urgently needed to standardize indications, promote safe techniques, and ensure equitable access for children and adolescents with severe obesity. This is my message, but I don't want to say goodbye without thank all the people that has collaborated with the paper. Some of them, many of them are here, and but not only the co-authors, but all the people that has answered the questionnaire. Most of them, more than 70% of them are presidents, past presidents, or former presidents of their national society. To recommend you to come to Malaga next year, there will be a fabulous European Congress, and I guarantee you that you will spend an excellent time in Spain. And yes, now, thank you all for listening.
That was a very nice presentation. When you did these surveys, were you able to differentiate which programs were using the ASMBS IFSO guidelines that we created in 2022 versus just BMI or some other criteria? Do you know how well we've infiltrated the...
It's very difficult to hear from here.
What I was asking you is in 2022, IFSO combined with ASMBS to produce guidelines that were not as dependent on BMI as the older ones. Do you know what percent of the programs that did have some credentials use ours?
Most of the countries do still base the indications based on BMI, unfortunately, I would say. But this is the data nowadays. Probably it's going to change in the near future because of the new tendency of better classifications of obesity.
We have time for one quick question from the floor.
Justin Reiner, United States, tremendous work. I was curious if your survey included any information on willingness to pay thresholds, because maybe that's how you shift the payer landscape.
Could you repeat, please?
Did your survey include any information about willingness to pay thresholds? So the amount of money somebody would be willing to pay for surgery, understanding the long-term benefits and gains?
No, we didn't ask for it. It would be a good point. And in fact, we analyzed how many countries do cover metabolic bariatric surgery for young people. But you have to take into account that although it's covered, it's not covered for everybody. So maybe just a part of the people, those who are really in need, are covered, or just a part of the procedure is covered. So we still have a lot of work to do in this field.
Thank you very much. That was a very nice presentation.
Thank you.
We'll move on to the next one by Dale Bond from the USA. Does becoming physically active after metabolic bariatric surgery facilitate positive metabolic phenotypic transition?
Morning, everyone. I have no disclosures. So obesity is a heterogeneous disease such that individuals living with obesity can vary in cardiometabolic risk factors and their susceptibility to developing cardiovascular diseases. So for example, individuals with the metabolic healthy obesity phenotype, or the MHO phenotype, they have excess adiposity, but they don't have the same indicators of cardiometabolic disease as those with the MUO, or the metabolically unhealthy obesity phenotype. Improving understanding of these phenotypes in the context of MBS is important, given the potential to elucidate variability in surgical outcomes, as well as the potential for MBS to stimulate transition from the metabolically unhealthy obesity phenotype to the metabolically healthy one. However, research on these phenotypes in MBS is still in its infancy. So research suggests that so far only a minority of patients have the MHO phenotype before MBS, and we also see large variability in the transition rates after MBS, with rates ranging from 37% to 89%. So at present, we have limited understanding of variability and why some patients with MUO before MBS do not transition to MHO after MBS. So one factor that may help explain variability is physical activity. However, no study has examined the role of physical activity in facilitating this transition after MBS, despite physical activity being a key modulator of cardiometabolic health, even in the presence of obesity, MHO having moderate to vigorous intensity physical activity and fitness levels, as well as lower sedentary time, and some studies, but not all, suggesting that physical activity and exercise can contribute to improvements in cardiometabolic risk factors after MBS. So to address these gaps, we had two aims for our study. One was to examine whether physical activity status is associated with increased odds of having MUO before MBS, and we hypothesized that participants who were insufficiently active would have an increased likelihood of having MUO compared to those who were sufficiently active. And for aim 2, we wanted to examine whether the change in physical activity status after MBS was associated with his transition. And we hypothesized that patients with MUO who became sufficiently active after surgery would have a higher likelihood of transitioning to MHO than those who remained insufficiently active. Our participants were from our prospective database at Hartford Hospital. They underwent surgery between August 2022 and June 2024. They were all adults. They had an average BMI of, or they had to have a BMI of at least 35. They also had to have sufficient data for classifying the phenotypes as well as PA status at pre-surgery. And for our aim number 2, they also had to have had reached 6 months post-surgery and then had sufficient data for both the obesity phenotypes and physical activity status at both time points. To classify the metabolic phenotypes, we used the National Cholesterol Education Program Adult Treatment Panel 3 criteria. And so patients who had at least 2 of these criteria were classified as unhealthy. Those who had less than were classified as healthy. To classify PA status was based on responses to the validated exercise vital sign and inactivity screener. This is a 2-item measure. And so for the first item, participants report on the average number of days per week that MVPA, for example, like a brisk walk, is performed, and then the average number of minutes per day that exercise is performed at this level. You then multiply these two items to calculate the average MVPA minutes per week. And in accordance with World Health Guidelines, participants who reported less than 150 MVPA minutes per week were classified as insufficiently active. Those who performed at least 150 were classified as sufficiently active. In terms of our analytic strategy for aim number 1, we use multiple logistic regression to examine the odds of having MUO based on physical activity status. Similarly, for aim 2, we also use multiple logistic regression to examine the odds of the transition in participants who became sufficiently active, so went from insufficiently to sufficiently active, versus those who remained insufficiently active. So for aim number 1, we saw that about 21% of participants before surgery had the MHO phenotype. On average, these participants were younger, there was a higher percentage of females, and they were less likely to report smoking during the first year before surgery. However, they were similar on race, ethnicity, and BMI. So in support of our hypothesis, we found that patients who were insufficiently active before surgery had a 137% higher likelihood of having the metabolically unhealthy obesity phenotype versus those who were sufficiently active. So for aim 2, of 232 patients who had both pre- and 6-month post-surgery data, 131, or 56%, had the MEO phenotype and were also insufficiently active pre-surgery. So I want to orient you to this figure. Each of the columns represents physical activity status. So on the left is they became sufficiently active. On the right is they remained sufficiently active. The shading within each of the columns represents the percentage of patients who either remained MUO or became MHO. So we found that participants who became active, so went from insufficiently active to active at 6 months post-surgery, had a 112% higher likelihood of transitioning to the metabolically healthy obesity phenotype versus those who remained insufficiently active. So our key findings, to summarize, so before surgery, 79% of patients had MUO, or 21% had the MHO. The patients who were insufficiently active had a more than 2-fold higher likelihood of having MUO versus those who were sufficiently active. A pre to 6 months post-surgery, 38% of patients with MUO transitioned. The patients who went from insufficiently active to sufficiently active had a more than 2-fold higher likelihood of transitioning from MUO to MHO versus those who remained insufficiently active. So the strengths of our study is the first, to examine the relationship between physical activity status and the metabolic phenotypic transition in the context of MBS, also our prospective design, and then also use of our validated inactivity screener and the criteria for classifying these phenotypes. However, findings should also be viewed in the context of certain limitations. Physical activity was self-reported. We didn't measure dietary intake, and we only had limited follow-up, only 1 follow-up period. So for future directions, additional research is needed to confirm our findings with device-measured physical activity, as well as to explore the role of other movement behaviors like sleep and sedentary time. We also want to understand whether these relationships persist over time and if physical activity can sustain the positive phenotypic transition despite weight recurrence. And at a later stage, if findings support, we want to develop and test adjunctive pre- and post-surgery physical activity interventions to help patients achieve this transition. To end, I'd like to acknowledge ISO for selecting our work and the opportunity to present, and particularly my colleagues who supported this work, particularly Dr. Pavlos Papasavas and Darren Tischler. Thank you very much.
Any questions from the audience? Dale, was there a connection between those that had the unhealthy MUO and complications, gallstones, liver disease, anything? Was there a connection?
In terms of, we looked at comorbidities as covariates, and they were not significant, so they weren't entered into the model.
All right, thank you very much.
Thank you.
And the next speaker is Dr. Leonardo Pereira. The title is Prediction of Hepatic Fibrosis in Patients with Obesity Undergoing Metabolic Bariatric Surgery with Simple Preoperative Bariatric, please.
Good morning. My name is Leonardo Lamy. I'm a 23 years old medical student from Fluminense Federal University at Rio de Janeiro, Brazil. Today, I'll present part of an ongoing project in which I'm one of the investigators. I'll show how routine preoperative variables can help estimate hepatic fibrosis in candidates for metabolic bariatric surgeries. I have nothing to disclose. First, let me explain what metabolic-associated steatotic liver disease is and why it matters for bariatric surgeries. MESLD, formerly called NAFLD, is now the most common liver disease worldwide. It affects about 1 in 3 adults, and obesity can triple the chance of having it. From the biological point of view, the preoperative bariatric population overlaps with MESLD. Visceral obesity and type 2 diabetes are central. Many patients also have a metabolism. Many patients also have a pro-inflammatory state and unhealthy diet. And genetic factors related to metabolism can promote liver steatosis and fibrosis. So, the pathology of this disease matches the patients we evaluate every day before metabolic bariatric surgery. The progression of this disease is dynamic. Over 8 to 13 years, some people with simple steatosis develop steatohepatitis. Among those with early fibrosis, some people progress to cirrhosis or liver decompensation, and a smaller group can reach advanced fibrosis in just 6 years. And that's the group we want to identify early to adapt our preoperative evaluation and reduce later risks. As we can see here in this data from Julian et al., there is an almost a linear relationship between visceral fat and prevalence of MESLD and liver fibrosis. This pattern is present in patients with overweight, the orange bars, and with obesity, the gray bars, but the effect is stronger in patient groups with obesity. These are the currently tools we use to diagnose liver fibrosis without biopsy. Several non-invasive methods exist, like FIB4, NFS, ELF score, FibroScan, and MRE. But there is a catch. These models were created and validated mostly in people with normal weight. So, when we apply them in a population with obesity, their accuracy drops, and that's our patients. It's in this context that our study tries to identify independent clinical and laboratory predictors of hepatic fibrosis in patients with obesity undergoing metabolic and bariatric surgery. Besides that, we had 2 more goals. First, to build a simple multivariable model with the fewest variables but the strongest impact. Second, to evaluate the model's performance, checking its discrimination through the area under the curve and its agreement with the biopsy results. So, the goal was not only to find associations, but to test if the model could actually support clinical decision-making in real world. In order to achieve our study aims, we designed a cross-sectional study with prospectively collated data. It was conducted in patients eligible for metabolic bariatric surgery according to the criteria of the Brazilian Federal Council of Medicine. All patients underwent clinical and laboratory assessment before surgery, and intraoperative liver biopsy was used as the gold standard for fibrosis diagnosis. We analyzed age, sex, body mass index, waist and neck circumferences, diabetes status, glycated hemoglobin, liver enzymes, platelet count, creatinine, and INR. With this data, we ran our analysis in our studio. First, we checked if all the data were complete and usable. Then, we tested which variables were independently associated with fibrosis, and how each one influenced the chance of having the disease or not. We used binary logistic regression, including both clinical and laboratory variables. Based on the results, we built a predictive model using those significant variables and tested if it could correctly identify fibrosis in patients with obesity. Let's check the results. In our logistic regression model, we found 4 predictors of liver fibrosis, all with p-value below 0.05. The most important variable was platelet count. Lower values were strongly associated with fibrosis, reflecting early portal changes. Next came age. Older patients had a significantly higher risk. Then we had neck circumference, which also was positively associated with fibrosis risk. And finally, type 2 diabetes. Although still significant, it had a smaller impact in our model. Using just these 4 variables, we created a model to estimate fibrosis. Our data set is still growing up to improve the balance and the accuracy of the function, but we brought here our preliminary results today to share them with you. Let's take a look at how our model performed in practice. We reached an area under curve of 0.725, which shows moderate discriminative ability. That means the model was able to separate patients with and without fibrosis reasonably well, using only simple preoperative variables. When we tested its diagnostic performance, we found sensitivity around 70%, specificity close to 63%, and a positive predictive value of 80%, which is clinically useful. That means when a model predicts fibrosis, it's usually right. This is especially important when decision who should go to biopsy. Of course, the overall accuracy was about 68%, and the negative predictive value was lower, around 49%. This tells us the model is not strong enough to rule out fibrosis safely yet, but it does help us to identify higher risk cases with reasonable confidence. We are still improving this model with new data, but these early results are promising. Our model had some clear strengths. It's simple, low cost, based on data already collected before surgery. And it's not perfect. It's a single-center cross-sectional study and still need external validation. But the early results already point to a promising clinical tool. Now, summarizing the key points, MASLD is highly prevalent in bariatric patients, and fibrosis can progress silently. Current non-invasive tools have low accuracy in bariatric population. Our model used routine variables and showed good predictive value for identified fibrosis. The model must be a practical and low-cost approach that can help triage patients for further testing, like biopsy. We are still refining the model, but it already shows promise for real-world use. Thank you for your attention.
Any questions from the audience? Leonardo, very nice project, nice presentation. Question for you. You said it was only 10% diabetes. Can you say with it only being 10% that it's influencing outcome?
Yes, diabetes was the lower variable that influenced our model, and patients with diabetes not have a 10%, but in the scale of the model, it had a 10 chances to develop the fibrosis when compared to the other variables.
Is a predictor cervical factor associated with obstructive sleep apnea?
Sorry, I didn't understand.
All right, I think we'll move on here. The next paper is metabolic bariatric surgery can be safely performed in patients over age 75. Insights from the MISQUIP database. Dr. Izabela Karpinska from Poland.
Yeah, good morning, ladies and gentlemen. As been said, my name is Izabela Karpinska, and I am a general surgery resident and also PhD candidate at Jagiellonian University Medical College in Krakow in Poland. And today, this is my pleasure to present the results of our research in which I've been involved during my research fellowship in the United States at the beginning of this year about the safety of bariatric surgery among patients aged over 75 years. I've got nothing to disclose. And as we all know, historically, age has been considered as a relative contraindication for bariatric surgery until 2022, in which ASMBS and IFSA organization come up with the new guidelines for bariatric and metabolic surgery, in which they removed the upper limit, age limit for eligibility. And sorry, I'm a little bit stressed. Yeah, and this was the milestone change, which causes that the elderly people become the growing population among bariatric surgery. As you can see, we annually performed 300,000 bariatric procedures worldwide, and up to 10% of them are performed among elderly patients, patients aged over 65 years, which gives us around 30,000 of procedures among elderly population every year. Despite this huge growth of the population, we still have very few research addressing the safety and efficacy of bariatric surgery in this population. I found this meta-analysis from 2020, which addresses the outcomes after bariatric surgery in the elderly population. It includes 20 studies and more than 8,500 patients. And the authors concluded that the bariatric surgery can be safely performed and can be an effective way to treat morbid obesity among elderly patients. However, when we look closely to the cohorts included into this meta-analysis, we can see that the mean age varies around 62, 63 years, which leaves a huge gap in the literature regarding the older group of patients. So in the light of these facts, we planned the study to evaluate the postoperative complications after primary bariatric surgery among patients aged 75 or more years. And we wanted also to compare the sleeve gastrectomy and Roux-en-Y gastric bypass procedures in terms of safety among this population. We retrospectively analyzed MBSA QIP database within 8 consecutive years. We included all patients who were aged over 75 years, who underwent primary bariatric procedures and completed 30 days of follow-up. We excluded patients due to incomplete data, the patients who underwent other gastric resection, hand-assisted or single incision approach, removal of gastric bypass, intragastric balloon placement, and all of the emergency cases. The primary endpoint was the postoperative complication, which happened within 30 days after the surgery, and the definition of complication was any deviation from the normal postoperative course. And as for the statistical analysis, we use comparative and descriptive statistics with the use of appropriate tests, including chi-square, Human-Whitney, and T-student. As you can see, at first stage, there were nearly 5,000 patients over 75 years who underwent primary laparoscopic or robotic bariatric treatment. Unfortunately, we needed to exclude more than 1,100 of them because they didn't meet the inclusion criteria. And subsequently, we excluded 66 more patients due to loss to follow-up. And finally, we included into our analysis more than 2,500 of patients with mean age 76 years and the preoperative BMI at around 41 kilograms per square meter. Most of our patients were women with independent functional status. The 3 most common comorbidities were hypertension, dyslipidemia, and obstructive sleep apnea. As you can see from this graph about the ethnicity, The majority of our cohort was represented by the white race, and the most popular bariatric procedure performed was sleeve gastrectomy, followed by Roux-en-Y gastric bypass. And the overall mortality was documented at 0.3%. Overall morbidity reached up 10.4%, whereas severe complications occurred in around 6% of analyzed patients. And these findings come along with existing literature regarding the younger adults as well. And the Clavin-Dindo classification graph shows that among the patients who experience any complication, the majority of them experienced the mild adverse events, which can be dealt with without using any additional revision of surgery. As for the comparison between sleeve gastrectomy and Roux-en-Y gastric bypass, we can see that Roux-en-Y gastric bypass was associated with significantly higher risk of morbidity, mortality, significantly longer hospital stay, and has higher risk of reoperation and hospital readmission. When we look at the particular adverse events assessed in the database, we can also see that the patients who underwent Roux-en-Y gastric bypass had higher risk of developing some adverse events like deep surgical site infection, bowel obstruction, bleeding, postoperative renal insufficiency, pneumonia, and sepsis. So to sum up, our study provides the evidences that the bariatric surgery can be safely performed and can be a safe method of obesity treatment among patients aged over 75 years or more, with the comparable similar mortality and morbidity rates compared to the younger adults cohort. And also, as the sleeve gastrectomy showed the significantly lower mortality and morbidity rates compared to Roux-en-Y gastric bypass, it should be considered as a first option in this high-risk vulnerable population. Thank you so much for your attention.
Any questions from the audience?
A great presentation. Papa Savas from the United States. MBS script changed the description of complications around 2020. Before 2020, for example, anastomotic leak was not a field. So how do you deal with this? And do you see any difference in the incidence of anastomotic leaks or bowel obstructions before or after that change in MBS script?
During the browsing through the data, I manually checked the additional sheet in the Excel paper in which you have the actual definition, which was what they meant by the number in the column, and I do it manually to check and to separate the bowel obstruction and all of the leaks and all of the particular side effects that happened.
When you compared sleeve and bypass, did you control for any comorbidities or other factors?
No, it was just a comparison between independent groups.
Thank you.
Isabella, it looked to me like the range was 75 to 77 or something, very, very narrow range. Did you notice a big difference between, say, 80 and 75? And also, what was your upper limit?
You're talking about the age?
Yes.
I think, as I remember, when I do the analysis, there were just 2 people who had the 80 years included into this database, so I didn't really check the differences.
Right. We'll go to the next paper now from Dr. Mohammed Hani, a randomized controlled trial of ring augmented versus standard sleeve gastrectomy in class 4 obesity, BMI greater than 50, 3-year outcomes.
Thank you so much. It's a big honor to be here with you. Thank you. I have nothing to disclose. Dear colleagues, we all of us know that the sleeve gastrectomy is the most commonly performed procedure due to simplicity and due to good midterm outcomes. But we have seen concerning long-term outcomes. One of the meta-analyses that analyzed patients with more than 7 years follow-up found that over a quarter of the patients have recurrent weight gain, and near 20% of them require revision surgery due to pouch dilatation and neurohormonal adaptation. So this is a big challenge for the patients with BMI above 50. We see the literature that the peak weight loss after sleeve gastrectomy is 30 to 35 total weight loss percentage at the 18 to 24 months, and this dropped after 5 years. It looks adequate, but often insufficient for sustained remission. So, in the literature, sleeve gastrectomy underperforms in those type of patients, and many studies are comparing those patients with a lower BMI, and they found, for example, Emmanuel et al., that they are durable. They are achieved well, but they're less durable. Some will have a striking results that these patients is underperforming with sleeve gastrectomy, and the revision rates are high. So this is cases compelling that let us found some enhancement to the procedure if we choose this. So the ring augmented sleeve gastrectomy, the ring itself is non-adjustable ring placed around the proximal sleeve 3 to 5 centimeter from the gastroesophageal junction for the hypothesis that it maintains restriction and prevent dilatation. So the evidence is present but limited. Fink et al. At 5 years conducted RCT and found that patients with ring augmented sleeve gastrectomy achieved well with fewer conversion rates, and also this is proved by one of the meta-analyses that also found that they achieve more 8 to 10% of excess weight loss. But the studies have mixed BMI populations and limited data in class 4 and 5 obesity specifically, so we need a dedicated RCT in the BMI of above 50 kilogram per meter squared. So we conducted a single-center, single-blinded RCT with ring augmented sleeve gastrectomy versus standard sleeve gastrectomy. We followed up the patient for 36 months. The primary endpoint was the percentage of total weight loss. Many secondary endpoints studied that recurrent weight gain, gastric pouch volumetry, metabolic abnormalities, relapse complications, endoscopic findings at 3 years, lab parameters, and patient-reported outcomes. We included patients with above 50 BMI with 50 kilogram per meter squared and provided informed consent to take part in the trial. And we excluded patients with active and have previous GERD or hiatal hernia, prior bariatric surgery, refusal of ring replacement, planned pregnancy during follow-up, active malignancy, uncontrolled psychiatric disorders and substance abuse. And we choose this definition according to the last Delphi consensus that recurrent weight gain as the gaining of more than 30% of initial surgical weight loss from the nadir, or recurrence and worsening of the obesity-related complication that was an indication for surgery. Okay, this is our consort. So we recruited the patients from Jan 2021 to Jan 2022, where there was 1,900 patients. After the application of exclusion criteria, we have randomized 218 patients. Those patients, as usual, the cohort predominated by females. The age is not different between the two groups, and the BMI also was not different between the two groups of patients. The mean BMI was 53.8 kilogram per meter squared, and the strong part here that 200 patients completed the complete follow-up. So follow the technique here with me from clockwise. So the technique of placement here, we can applicate the ring, either use perigastric or Barth-Flass technique from the patient's left to the patient's right with little dissection. Again, we must keep it loose around the stomach, and with ensuring that a 5 millimeter instrument can pass between the ring and the pouch. And we need to fix the ring through the holes by non-absorbable sutures to avoid slippage. Moving to our results, percentage of total weight loss at 36 months, it's expected that we see the difference later, because at the first 2 years they are almost the same, but at 3 years, we found at least 3.3 percentage points difference for excess weight loss, total weight loss percentage in patients with ring-augmented sleeve gastrectomy. Regarding the pouch volume analysis, we found that the patients with ring-augmented sleeve gastrectomy have smaller pouch volumes. This is what was hypothesized. As for recurrent weight gain, we have 5.9% of patients with ring-augmented sleeve gastrectomy have regain compared to 16.3%. For the patient-reported outcomes, the food tolerance was consistently better, of course, in sleeve group. This is, of course, we know that the ring causes more restrictions, so I think we can expect a trade-off for improved weight control, and both groups show no difference in short form 36 questionnaire, but they achieve significant improvement. For safety profile, we have similar operative outcomes, comparable early complications. We have one leak in the sleeve group, one patient leaked in the sleeve group, standard sleeve group, treated with a stent for 6 weeks, and bleeding one in each arm. The proportion of patients experiencing relapse of any obesity-related disease was significantly higher in standard sleeve group patients. And at endoscopy at 3 years, we didn't find any increase in GERD between both cohorts, but it's slightly higher in the patient with ring-augmented procedure. Esophagitis, most of them esophagitis grade B and C was seen in 2% versus 1% respectively. We removed the ring in 2 patients due to intolerance, no erosion and slippage. And revision rate at year 3, we have conversional RYGB in 8 patients of standard sleeve versus 2 patients in ring augmented due to weight regain and reflux. When we compare to the literature, we found that the results are the same. Lemes et al. In retrospective analysis found also that ring augmented doing better with 0 failure rate. And this is also replicated in many studies by Fink and our aerial study published. When we see the GERD and ring-related complications, we GERD outcomes. No significant difference between the 2 cohorts published in the literature, but the additional morbidity, that occasional dysphagia, and mostly it's diet managed, and rare ring removals. And the complications related to the adjustable gastric band was too high compared to this type of ring, which is in literature from 3 to 11%. So how rings works? Straightforward, fixed outlet, 4 to 5 centimeters below the gastroesophageal junction, prevents reservoir expansion, slow gastric emptying, activates ileal brake, maintains restriction long term. So the clinical implications from the study that we consider the ring augmented sleeve gastrectomy for patients at high risk for recurrent weight gain, especially those with BMI above 50. So, but preoperative counseling is important to balance weight durability versus food tolerance. So the strengths of the study, that is the first dedicated RCT in patients with BMI above 50 kilograms per meter squared, and this confirmed benefits extend to most patients with severe obesity. And we evaluated the pouch by volume by the CT volumetry, and we did endoscopy for most of the patients at the 3 years. And the study limitations is also single center, at baseline imbalance in some laboratory parameters between patients. 36-month follow-up may miss late complications. And we have here the range from 50 to 5.8, 5.9.9, and maybe we need to test for a higher class 5 obesity. The study was adequately powered for weight outcomes, but not for all secondary endpoints. So our future research directions that we need to do multi-center RCTs with extended follow-ups up to 5 years, and we need to integrate our data inside the IFSO registry. Maybe you can collect more insights. So we need to also do cost-effective analysis. By the way, the patients here didn't pay for our institute covered the cost, and we need to refine patient selection criteria. Conclusion, ring augmented sleeve gastrectomy provides superior midterm weight loss outcomes in patients with a BMI above 50 kilograms per meter squared, significant reduction in clinically meaningful recurrent weight gain, comparable safety profile, but the trade-off is reduced food tolerance for better weight control. For selected patients with severe obesity at high risk for recurrent weight gain, ring augmented sleeve gastrectomy offers an effective anti-regain strategy at midterm at least that should be considered in our armamentarium. Thank you so much.
Nice presentation, Mohammed. Question for you. Banding bariatric cases has been around for decades, way before even Dr. Phoebe was using the Phoebe ring.
Yes.
How come it hasn't caught on? You're presenting wonderful data here, and yet most of the people will go home and not do one. What are we missing?
What we missing?
Yeah, what does it take to convince people to use the ring?
Yeah, convince the people to do that, yes. Because we know that sleeve gastrectomy, all the time you have a certain area of plateau followed by regain, okay? Maybe this is not a problem for some of the patients that you say that their BMI is lower than this category. But for patients with BMI like this, we need the patient all the time feel more satiety and restriction. So I think this part of patients, when you start to do this surgery, try to use this cohort of patients, not to do it early. And when you are convinced with your results, then go for lower BMI.
Any questions? Yes, sir.
Professor, that was a very nice presentation. Can I just ask you two technical questions? One, you said you calibrated onto a bougie with a diameter of 5 millimeters. Did I get that right?
You know, the calibration tube is 40, okay? And
40
you put
French.
40 French, yes.
Okay. And is there any significant difference in the advice regarding diet between both sets of patients?
Again, I don't hear.
Is there any significant and dietary advice that you give both sets of patients? Because presumably, the ones that have the minimizer ring would have to be on a soft or pureed diet long term.
I don't get your question.
Okay. Between the banded sleeve
Yes.
and the non-banded sleeve, do you give any difference in the dietary advice?
No, the same dietary regimen for all the patients from the start.
So they can still eat
Yes,
solid food?
yes, and you
solid
will find,
food.
yes.
Thank you.
Okay.
Okay, we're going to move on. Performance of FIB4, NIFs, and APRI in detecting advanced fibrosis in adults with obesity and metabolic dysfunction associated steatotic liver disease. And this is Dr. Jesus Pinto Hilera from Peru.
Thank you. Good morning to all. I am very grateful for being here presenting this work. I have nothing to disclose. Muscle D affects 38% of all the population worldwide. It's the most common chronic liver disease and is one of the most frequent comorbidity in people with obesity. There is a challenge in the evaluation of the fibrosis stage in our daily practice. We have the liver biopsy, which is the gold standard, but it's usually not performed. We have the elastography, like FibroScan or shear wave, MRI, but it's used in high suspicious cases. We use also serum markers, but they are a little inaccessible in some places. And finally, the serum scores that are cheap, easy to use, and is vastly used in our daily practice. This was an analytical cross-sectional observation study with data obtained from institutional database between 2016 and 2021. The inclusion criteria were age between 18 and 65 years old, patient undergoing bariatric surgery, and steatosis was assessed by liver biopsy. We exclude patients with harmful alcohol use, typically 20 and 30 grams per day, between females and males respectively, have a patient with previous bariatric surgery and liver biopsies with less than 11 portal spaces, and patient with an alternative cause of fibrosis. We use 3 of these score tests, APRI, FIB4, and NFS. They're each one with their own cutoff point to assess high or significant fibrosis. We use wedge and cold scissors biopsy at the start of every surgery, and this was reviewed by 2 expert pathologists. First, we did a quality control of the database. If there was any missing data, we went to the original medical records. We used the statistical software Stata version 16. Chi-square test, Fisher-Stas test, student test, men with EU tests were used according to variable characteristics. We used we reviewed the performance by our curve. The optimal cutoff was calculated by new methods, and we did a sensitivity analysis with sensitivity, specificity, positive and negative predictive values. The protocol had ethyl approved. We include 426 patients. Approximately 1/3 had grade 1 obesity, another third grade 2 obesity, and another third grade 3 or higher. The median of the BMI was 37.6. 18% of those had high blood pressure, 18% had diabetes, and 91% had insulin resistance. 15 of those have hypothyroidism. All of patients had steatosis, but 95% of them had steatohepatitis. There was significant fibrosis according to the liver biopsy in 26% of patients and advanced fibrosis in 9.6% of them. All three tests identify fewer cases of fibrosis compared to biopsy. FIB4 had only 0.2%, NFS had 1.4%, and APRI 4.7%. Patients with advanced liver fibrosis were older. They had a higher glucose, higher OMA-AR, and higher AST levels. There was an association between advanced fibrosis and having severe obesity, higher waist circumference, the hypertension, and diabetes, but not with insulin resistance and hypothyroidism. This was the outlook for significant fibrosis, where all the three tests have a poor performance with 0.6. And when we analyze in advanced fibrosis, that is what we care, APRI maintains a poor performance, whereas FIB4 and NFS show acceptable performance. In the subgroup of females and patients with severe obesity, there was a slight improvement in the outlook. And in the diagnostic performance of these tests, all three had very low sensitivity and very high specificity, which is a characteristic for not a screening test, but a diagnostic confirmation test. When optimal cutoff points were calculated, there was a lower point. We gained sensitivity at cost of some specificity, but we improve likelihood ratio with NF4 maintaining the best correct classification. These calculated cutoff points went 0.3 in APRI, 0.5 in FIB4, and -2.1 in NFS. We conclude that non-invasive scores in patients undergoing metabolic bariatric surgery tend to underestimate the grade of fibrosis in preparative assessment. The scores perform from poor to acceptable, with NFS and FIB4 showing better discriminative availability, especially in women and in adults with severe obesity. The commonly used and recommended cutoff points are oriented towards gaining specificity, but with very low sensitivity, which makes them less valuable as a screening test. NFS achieve a higher percentage of correct classification with using new empirical cutoff points that optimize the balance between sensitivity and specificity. Thank you.
Any questions from the audience? Anybody?
Yeah, I have one question. You mentioned that 95% of your patients had steatohepatitis.
Yeah.
This is not what we get. It's maybe 20% in our group.
Yeah, we know that is also something we have some interest, but this is consistent with other series in different years. We have in Peru, mostly in South America, very high rates of steatosis and steatohepatitis. This is something that we think it could be according to the study of the liver biopsies, the person who reads the biopsies, but yes, it's a different number of frequency here in Peru. Thank you.
The next paper is Can Metabolic Dysfunction Associated Steatosis liver disease be well classified by a visual assessment during bariatric and metabolic surgery? Oh, did I just read the same one twice?
Hi, good morning. It's great to be here again.
Oh, it's the same.
My name is Leonardo Lamir. I'm a medical student at Fluminense Federal University in Rio de Janeiro, Brazil. Today, I'll present part of a project in which I'm one of the investigators. I will show how intraoperative visual inspection compares to liver biopsy for assessing hepatic steatosis and fibrosis during metabolic bariatric surgery. I have no disclosures. First, let me explain what metabolic-associated liver disease is and why it matters for bariatric surgery. As I've said, MESLD, formerly called NAFLD, is now the most common liver disease worldwide, and it affects about 1 in 3 adults, and obesity can triple the chance of having it. From the biological point of view, the preoperative bariatric population overlaps with MESLD. Visceral obesity and type 2 diabetes are central. Many patients also have pro-inflammatory stage and unhealthy diet. Genetic factors related to metabolism also can promote liver steatosis and fibrosis. So, the pathology of this disease matches the patients we evaluate every day before metabolic and bariatric surgery. The progression of the disease is dynamic. Over 8 to 13 years, some people with simple steatosis develop steatohepatitis. Among those with early fibrosis, some progress to cirrhosis or liver decompensation, and a smaller group can reach advanced fibrosis in just 6 years. And that's the group we want to identify early, to adapt our preoperative evaluation and reduce later risks. As very good presented here before, these are the currently tools we use to diagnose liver fibrosis without biopsy. Several non-invasive tools exist, like FIB4, NFS, ELF score, FibroScan, and MRE. But there is a catch. These models were created and validated mostly in people with normal weight. So when we apply them in populations with morbid obesity, like the bariatric patients, the accuracy drops. So let's take a look about the routine bariatric surgery that's common for surgeons to assess the liver visually. They usually base their judgment on macroscopic aspects such as color, texture, or irregular surface. Our study was designed to evaluate how useful this practice really is when compared with histology, which is the gold standard. To illustrate this point, let's analyze cases where visual and histological assessments diverged. These examples show how the microscopic impressions do not always reflect histological reality. For example, in case B, the yellowish aspect suggested severe steatosis, as you can see at the visual judgment, S3. But the biopsy confirmed only S1 steatosis with F1 fibrosis. Cases C and D looked similar on inspection, both visually judged as F3, as you can see on the presentation. But C liver had no fibrosis at all at the biopsy, while liver D showed advanced fibrosis, F4, both with over 40 portal tracts biopsy, a huge biopsy. This shows the risk of making clinical decisions based only on what the liver looks like is fail. With that in mind, we designed an observational study to test how well a surgeon's visual assessment of the liver compares with biopsy, which is the gold standard. In addition, we wanted to check whether visual inspection aligns with non-invasive tools such as controlled attenuation parameter, CAP, FIB4 score, and vibration-controlled transient elastography, VCTE. To do that, we conduct a cross-sectional study. All visual assessments were performed intraoperatively by a single experienced surgeon, and every patient had a standardized left lobe biopsy. analyzed by one pathologist using the Kleiner classification. In addition, we compared findings with FIB4, VCTE, and CAP. Our study included 310 consecutive bariatric patients operated between May and November of 2024. When comparing the visual scale to biopsy findings for steatosis, any degree of steatosis, we found a sensitivity of 96% and a specificity of only 13%. This means that while the surgeon was usually able to identify the presence of steatosis when it existed, the ability to recognize truly healthy livers was very limited. This pattern is reflected in the confusion matrix. Most cases classified as healthy visually turned out to have at least mild steatosis. So while the visual inspection could help identify steatosis, it wasn't reliable to rule it out. For fibrosis, visual inspection had a sensitivity of 45% and a specificity of 78%. This means it was able to identify fewer than half of the patients with histologically confirmed fibrosis, but was more accurate in recognizing those without fibrosis. Visual inspection frequently underestimated or overestimated the disease. Some patients classified as moderated visually had fibrosis at all, as you see highlighted at the third line of the table. And none of the patients with histologically confirmed advanced fibrosis were correctly identified visually. So, macroscopic evaluation often fails to reflect the true stage of fibrosis, and visual inspection is not an accurate tool to stage fibrosis during the metabolic bariatric surgery. We also compared the visual scale to non-invasive methods, specifically VCTE and FIB4 for fibrosis. For detecting any fibrosis, the visual scale had similar results to both VCTE and FIB4. However, when it came to distinguish between mild and advanced fibrosis, visual inspection actually overperformed both tools. It was significantly better than VCTE and FIB4. Still, both VCTE and FIB4 showed significant associations with histology. VCTE had the strongest correlation, and FIB4 was also statistically significant. These findings reinforce a critical message. While some tools may perform relatively well in specific scenarios, there is a need for better and more accurate methods to stage and detect fibrosis in patients with obesity. To conclude our presentation, visual inspection can help detect steatosis, but it's not reliable for staging, especially when we need to separate mild from advanced fibrosis. When it comes to fibrosis, visual judgment is even less accurate. It often leads to misclassification, either underestimation or overestimating severity. Non-invasive tools like CAP, VCTE, and FIB4 show better correlation with biopsy, but still have important limitations in patients with obesity. So, when staging is clinically important, liver biopsy remains the most accurate option. And this decision should be made before surgery, not just based on liver's appearance during the procedure. Thank you very much for your attention.
Thank you very much. Nice presentation. I have a question. It's the fourth presentation we hear this morning about whatever test we have to detect liver disease. And in the end, only biopsy is able to tell us what really happens in the liver. So should this federation not suggest that every single operated patient undergoes a liver biopsy during surgery? It's an easy test. It takes 2 minutes. It's not dangerous during surgery. Shouldn't we recommend this as routine?
So, as any invasive test, there is a risk. And the tests here, the non-invasive tests, wants to minimize these risks of the biopsy. 90% of the patients have steatosis when the bariatric patients, and about 30% has fibrosis. But it's a thing that we have to study more and debate here and over the world to see what's the better evidence show about intraoperative biopsy, percutaneous biopsy, its risks and its benefits.
Now I was talking about intraoperative biopsy.
Yes, as I said, intraoperative biopsy is common. Some academic jobs, some academic universities and hospitals do it as routine, but I've only seen this as protocol of research. I've never seen this as routine at the practice of all patients.
Thank you.
Thank you.
All right, the next paper, Efficacy and Safety of Tranexamic Acid Use in Metabolic Bariatric Surgery, a Systematic Review and Meta-Analysis by Dr. Lily Park of Canada.
Great. Hi, everyone. I'm Lily Park. I'm a resident from McMaster University from Canada. I'll be presenting our systematic review and meta-analysis on the efficacy and safety of tranexamic acid in bariatric surgery. I have no conflicts of interest to declare. So bleeding after bariatric surgery is reported to occur in about 1.5 to 3% of cases, and about 3% of those cases require reoperation for hemorrhage and is associated with significant morbidity. Prophylactic reinforcement strategies can be costly with variable efficacy in existing literature. Tranexamic acid, or TXA, is an antifibrinolytic agent that can be administered intravenously and shows promise in reducing perioperative bleeding rates. It's been shown to be very effective in other surgical fields like cardiac surgery, orthopedic surgery, and more recently in general surgery, but there's limited bariatric surgery evidence. Considering the unique profile of obese populations who are at baseline hypercoagulable, but also prone to bleeding, considering the extensive tissue dissection that's required, this highlights them as a population that warrants dedicated study. The last systematic review was published in March 2025 that included 1,121 participants. This was actually published after we started our study, but luckily since then, there have been 4 additional studies that were published, and so we thought that this was an opportunity to reevaluate the question with updated evidence. So the objective of our study was to determine the safety and efficacy of prophylactic TXA use in bariatric surgery. Outcomes of interest were broadly efficacy and safety outcomes, with endpoints including bleeding events, transfusion rate, hemoglobin reduction, length of stay, and operative time, and for safety, venous thromboemboli, pulmonary emboli, myocardial infarction, stroke, and myocardial injury after non-cardiac surgery, or MINS. So we followed the PRISMA guidelines, registered a Prospero protocol. We searched the Medline, Embase, and Cochrane databases from inception to April 2025. We included comparative studies that compared prophylactic intravenous TXA use versus non-use of TXA among bariatric surgery patients. Dichotomous and continuous outcomes were evaluated using the Mantel-Hansel and inverse variance model respectively, and random effects models were used. Among the 405 abstracts that were identified, we ultimately included 11 studies. This is a summary of all the studies that have been included, and altogether, again, 11 studies involving 1,990 patients. There were 5 randomized controlled trials, 6 cohort studies. 78% of patients were female with a mean age of 41 years. There were mostly sleeve gastrectomies with a few gastric bypasses, and TXA dosing was typically done by administering 1 gram at the start of the operation and a 2nd gram at the end of the operation, either as a bolus or as an infusion. So with regards to our results, for transfusion rate, there was a significant association with the use of TXA and reduced transfusion rate of 0.3% versus 1.7% in the TXA and non-TXA groups, respectively. This was a relative risk of 0.29, which was statistically significant, with very low heterogeneity as the I-squared value was 0%. When we did subgroup analyses by study design, RCT and non-RCTs, there weren't statistical significance within each of the subgroups individually, but there were also no subgroup effects by study design with a p-value of 0.9 and I-square value of 0%. Bleeding event was defined as a bleeding episode that was associated with hemodynamic changes, a predetermined hemoglobin drop of 2 milligrams per deciliter, or requiring some sort of intervention like reoperation, endoscopic intervention, or transfusion. Again, there was statistical significance favoring TXA use with 3.5% bleeding events in the TXA group versus 7.8 in the non-TXA group with a relative risk of 0.46, relatively narrow confidence interval, which was statistically significant with an I-squared value of 0%. Intraoperative blood loss was no different between the two groups. There was about a 10 mil difference, which again, p-value was 0.14. I-square value was significant at 87%. With the leave one out sensitivity analysis, this didn't really explain where the heterogeneity originated from. Change in hemoglobin was statistically significant, but possibly not clinically significant, as the mean difference was 0.24 grams per deciliter. Again, heterogeneity was quite low. Length of stay in hours was different by 2 hours, favoring the TXA group again. Again, statistical significance with low heterogeneity. Operative time was also statistically significant, favoring TXA use with a mean difference of 6 minutes. But again, the heterogeneity here was high, with an I-squared value of 81%. In terms of the safety outcome, across all 11 studies, 1,990 patients, there were no thromboembolic events that were reported in either the TXA or control groups. The POISE-3 trial looked at a composite safety outcome where they reported 2 out of 36 patients in the TXA group and 3 out of 40 patients in the control group experienced a safety event. But when you looked at the actual individual endpoints, these were all myocardial injury after non-cardiac surgery, or MINS. So again, there were no thromboembolic events that were identified. And there were no other serious adverse events reported across all of these studies. So our study demonstrated that TXA reduces transfusion rates, bleeding events, hemoglobin drop, length of stay, operative time without increased thromboembolic risk. This was largely consistent with the previous systematic review, but with our increased sample size from the last systematic review, it helped to increase the precision of estimates and as well enabled significant associations to emerge, such as a reduction in transfusion risk, which wasn't seen in the previous review. TXA is cost-effective, it's easy to administer compared to other options for reducing perioperative bleeding in bariatric surgery, like staple line enforcements with clips or oversewing or buttressing, which requires anticipation of bleeding sites that may not be always accurate. So in conclusion, TXA is safe and effective in bariatric surgery and should be considered for routine prophylactic use. In the future, there can be high-quality RCTs to help define optimum regimen and dosing for the bariatric surgery population. Thank you, and I'd be happy to take questions.
Very nice presentation. Do you know what the cost is for a dose?
I don't know the exact cost, but negligible, at least compared to all the other interventions that can be used.
I have a question. You mentioned that most of the studies included only sleeve patients, and there were only few bypasses. So I doubt you can conclude that it is effective in MBS in general. You can conclude that it's probably effective to prevent bleeding in sleeves, but the rest is speculation. Do you agree?
I do agree. I think for sure there's not enough numbers of gastric bypasses, but I think there has been enough investigation into efficacy and safety of TXA use in the broad general surgery population, and that's what can be applied. And I think what all of this information tells us with thousands of patients that have been enrolled in these trials is that there's not significant risk there's not significant risk, but perhaps not enough of a sample size to show an efficacy right now with the studies that have been performed. So I don't think it should necessarily prohibit use of TXA in these populations with the evidence that we have at this time.
Thank you. One question?
Yeah, Papasavas, USA. A challenging population in clinical practice are patients who need to start anticoagulation after bariatric surgery.
Yeah.
did these studies include any of these patients? And did they do like a subgroup analysis whether TXA had a prophylactic effect? And how long does the prophylaxis last?
Yeah, so I think the studies didn't, a lot of the studies didn't specify what their post-operative anticoagulation regimen were, but from what we know of how TXA works, it's an antifibrinolytic agent, so it stabilizes clots when they form. And so the thought that it shouldn't interact necessarily with the efforts for anticoagulation. In terms of how long it lasts, there have been some studies that say possibly a few hours to a few days. It's not clearly defined, and I think it's interesting because especially in the obese population, I think it's important to study that and understand that better, and I think that's why our next step should be looking at the best dosing regimen for these patients. Thank you.
Any further questions? The next paper is oral anti-obesity management medication after bariatric surgery, an RCT on naloxone, bupropion, after metabolic bariatric surgery by Dr. Gert Verkulen from the Netherlands.
Yeah, thank you very much. Sorry for the hard pronunciation of my name. I think my parents didn't thought that really through. Thank you to IFSO for being here, all out from the Netherlands. It's great to be here. We're going to talk about oral anti-obesity medication management after bariatric surgery in patients with recurrent weight gain. First of all, the study medication was funded by Good Life Pharma, so I have some conflicts of interest. And the study came to an early termination because of the stop of funding of medication. First, a little bit of background. Recurrent weight gain after metabolic bariatric surgery occurs within 10 till up to 40% of patients after several years. It has different causes, as can be seen on the picture. Calorie deficit or over too much calories, too low of activity, your metabolism, hunger hormone or fullness hormone. And how to solve this problem? Yeah, there are several ways. Lifestyle modifications, surgery, or in our case, obesity management medication, where I think all of the above are necessary. In this study, we looked at naltrexone bupropion, known as MySimba. The study design was a multi-center study, which was coordinated by Zuiderland Medical Center, our center. And we randomized between a group on Back on Track. Back on Track is a lifestyle intervention program, consists of a multidisciplinary team, where you get 4 appointments, and the last one is with the MD. It's a program of 22 weeks, and we randomized between that Back on Track and Back on Track with the uses of MySimba. After 22 weeks, we assessed the primary outcome of successful weight loss, defined as 5% of weight loss, and we looked at some secondary outcomes. Additionally, we looked at a control group, which consists of a non-metabolic bariatric surgery group, where we looked at serum levels within the blood to make a comparison between our medication intervention group and the non-metabolic bariatric surgery group. Eventually, like I said, the study came to an early stop, so the inclusions were a little bit less than expected. 96 patients were eligible, of which 47 excluded due to exclusion criteria. 49 met inclusion criteria and 12 declined study participation, which we got left with 37 patients after randomization between 18 in the Back on Track group and 19 in the medication group, the MySimba and the Back on Track, and additionally 14 non-metabolic bariatric surgery patients. When we look at the baseline characteristics, I think what's important to see that there is no significant difference between groups. Overall, it's a quite normal metabolic bariatric surgery group. Then over to the results. As seen on the top of the graph, within the MySimba group, we started with 19 patients and we got the data on 15 patients. And within the Back on Track group, half of patients got lost to follow-up. We did an intention to treat analysis. with those 15 patients. Some patients stopped early with their medication, but we took their findings into account for this intention to treat analysis, where we got 7 patients with successful weight loss in the medication group and 0 in the back on track group. When we did a per protocol analysis, only 7 patients in the mycema group completed the entire protocol, and again 9 in the back on track group, where we still got a significant difference between successful weight loss, where on the bottom you see the median total weight loss of 6.3 within the medication group and 1.5 in your back on track group. As secondary results, we looked at the adverse events within the medication group. Of the 19 people within this group, 10 had adverse events, of which 4 stopped with the treatment. Those were in the intention to treat. We looked at them as well. The dosage of pills, it's nice to see that 60% of patients became to the maximum tolerated dosage of 4 pills. And then the additional results where we made the comparison between the control group, the non-metabolic bariatric surgery group, and your medication group, where you see a significant difference in serum levels, but your total weight loss is comparable, which leads us to the conclusions that patients receiving mycema medication and back on track on an adequate dosage, so the statistically significant increase in successful weight loss at 22 weeks compared to your back on track, as 40% of patients discontinued the medication due to side effects. Careful patient selection and expectation management is of great importance. And it's interesting to see that patients in the surgery group experience similar side effects, but the blood plasma level do, however, show a difference. And I want to thank you for your attention. Any questions?
It seemed to me you had very small numbers. Was this study powered to be able to show a difference?
The study was powered on 150 patients, between 40% in your back on track and 6% in the medication group. So the power was quite higher than we eventually got, yeah. And it was powered on the successful weight loss. Yeah.
Okay, and also you had 40% of patients that discontinued because of side effects. Would you then consider this to be a serious treatment?
I think that for the people who had the side effects and want to continue the study, as well as who hadn't the side effects, therefore it's quite valuable to use. I called the patients, and some of patients wish to continue the medication after the study, which unfortunately wasn't possible. But for those patients, I think it's possible to use this medication for recurrent weight gain after bariatric metabolic surgery, yes.
Thank you.
And you have pretty much short-term results, just short of 6 months. Yeah. You suggest these patients should be maintained on the medication long-term? Do you have any idea about longer-term results?
Good question. It's a little premature, but when we look at the 1-year follow-up, so they stopped at 22 weeks with the medication, they regain weight, what we know of the anti-obesity medication. Yeah, it's comparable.
Dale Bond, USA. So I might have missed it, but was the goal to prevent weight recurrence, or was it to treat weight recurrence? To treat weight recurrence, so recurrent weight gain, yeah, with the medication. But we saw within the back on track, it's only to prevent further recurrent weight gain. Yeah. So the conclusion of your back on track is further recurrence, and within the medications you see additional weight loss. So did all participants, were they experiencing weight regain at the time that you enrolled them?
Yeah. So they got their primary surgery, they regained weight, and after that we involved them in the study. Yeah.
And was there any difference in average weight regain between the 2 groups when you started?
No, there was no difference in. No, it was quite comparable. Yeah.
Okay, thanks.
But it's limited due to a small amount of numbers of patients.
Thank you very much.
All right, thank you.
All right, moving right along. The next paper, field testing a bariatric specific patient-reported outcome measure for the Australia and New Zealand Metabolic Bariatric Surgery Registry. This is for Dr. Elisa Boudin from Australia.
Ah, no.
Go to the next.
Good morning, everyone. I'm going to present this study, Quality of Life 2 years after Roux-en-Y gastric bypass, a comparison of a long versus short BPL limb configurations in the BPG-1 multicenter study. I have no disclosures, except that this study received a research project grant from the Spanish Association of Surgeons in 2020. It's a pleasure for me to be here to present the results of this study that addresses a key question in bariatric surgery. Can the length of the biliopancreatic limb significantly influence weight loss and quality of life after Roux-en-Y gastric bypass? As you know, Roux-en-Y gastric bypass is one of the most performed operations in bariatric surgery. Still, not all patients respond equally. So this has led to explore different configurations of Roux-en-Y gastric bypass to improve the outcomes. One of the most debated aspects was the length of the intestinal limbs, specifically biliopancreatic limb or BPL. Several randomized controlled trials have shown that lengthening the alimentary limb does not provide additional weight loss. However, emerging evidence suggests that a longer BPL may enhance weight loss and possibly improve quality of life. There is also concern that longer BPL may negatively impact quality of life through altered bowel habits, nutritional deficiencies, or complications. There is still no consensus regarding the optimal common channel length in a standard Roux-en-Y gastric bypass. And total small bowel length and common channel are rarely measured when performing a Roux-en-Y gastric bypass. So our objective was clear: to assess whether a longer biliopancreatic limb in Roux-en-Y gastric bypass improves both weight loss and quality of life over a 2-year follow-up. We designed a prospective, single-blinded, multi-center randomized clinical trial registered with this NCT number. The inclusion criteria were adults older than 18 years old, eligible for Roux-en-Y gastric bypass with BMI between 35 and 50. The primary outcomes which allow us to calculate the sample size were a percentage of excess weight loss and percentage of total weight loss at 2 years. And secondary outcome was quality of life measured by the Barros scale. All procedures were laparoscopic. Pouch length was 6 centimeters, calibrated with 36 to 39 French bougie. Patients were randomized to either a long biliopancreatic limb of 150 centimeters with a short alimentary limb of 70 centimeters, or a short biliopancreatic limb of 70 centimeters with a long alimentary limb of 150 centimeters. The total small bowel length and common channel were measured in all patients. Gastrojejunostomy and jejunojejunostomy were performed with a linear staple, and mesenteric defects were closed with barbed non-absorbable sutures. Between January 2019 and February 2022, 98 patients were included and randomized, 49 in each group. The common channel length was similar in both groups, around 412 centimeters in short BPL group and 423 centimeters in long BPL group. Baseline characteristics like age, gender, BMI, and obesity-related diseases were similar in both groups. And we achieved a 98% follow-up rate at 2 years. Now the results. At 24 months, percentage of excess weight loss was 89% in the long BPL group versus 78% in the short BPL group. And percentage of total weight loss at 24 months was 39% in the long BPL group versus 33% in the short BPL group. Quality of life assessed via the FibroScan was significantly better in the long BPL group at both 12 and 24 months. 74.5% of patients reached an excellent FibroScan score versus 46.8% in the short BPL group. These results were similar at 12 months. These findings are consistent with other randomized controlled trials. For example, in 2018, Homan found improved quality of life with longer BPL at 24 months, with both VAROS and REN36 scales that disappeared thereafter. For example, the Elegance Redo trial similarly found improved quality of life with long BPL with REN36, but the effect was gone 48 months later. However, one randomized controlled trial of NIRGAR with a 5-year follow-up found not quality of life difference, although longer bibliopancreatic limb was associated with more diarrhea. Larger trials are ongoing, like, for example, the SLIM trial, but at present, Rose's quality of life data by limb length variation is lacking. This emphasizes the importance of long-term follow-up. Our 5-year analysis is ongoing. Weight loss remains a strong determinant of patient satisfaction and quality of life, especially physical well-being. In conclusion, a longer BPL configuration in gastric bypass may lead to significantly better weight loss and higher quality of life scores at 2 years. However, we must remain cautious. Further research with longer follow-up is needed before implementing changes in surgical practice. Thank you very much. I'll be happy to take any questions you may have. Thank you.
Any questions from the audience?
Darren Tischler, United States. I commend you that you actually measured the total or intestinal length. I think that's been lacking from studies in the past. But why did you choose 70 centimeters for the alimentary limb in the long BPL group, as opposed to something a little bit longer to prevent bile reflux?
Yeah, because the minimum, before we always do the Roux-en-Y gastric bypass with 150 centimeters of alimentary limb and 70 centimeters of biliopancreatic limb. Then, if patients was very metabolic patients, we longer the biliopancreatic limb to 100, and there are a lot of studies that show better weight loss and better remission of diabetes with 2 meters of biliopancreatic limb. And we thought we want to look for in our people, in our hospital, what happened. And we decided to change the same measure because I think that tall and combine alimentary limb with biliopancreatic limb is important, and common channel is important, and we never measure it. with 70 centimeters of alimentary limb, it's difficult to have a biliary reflux, I think so. And in these patients, in 100 patients, we don't have biliary reflux. But there are a lot of studies that, for example, said biliopancreatic limb of 2 meters and compare different longer of limb lengths. And we think that it's very important to, we have 220 centimeters of the sum of alimentary limb and biliopancreatic limb.
Thank you.
Oh, thank you.
All right, the next paper.
Yeah, I have a comment, if I may. I think that the complex of all these studies is that is 3 variables: the common channel, the alimentary, the biliopancreatic. So I think that to establish a 70-150 is just to keep the common channel exactly the same, because otherwise it's really confusing. I think so.
Thank you. The next paper, metabolic bariatric surgery, eating behavior, phenotypes in pre and post-operative stages, Dr. Pablo Omelenchuk from Argentina.
Good morning. Thank you for allowing us to present this work that was done by the psychology team of our group. I'm going to show the result of this work about eating behavior phenotypes in pre and post-operative stage. We don't have nothing to disclosure. So the objective of this study was to describe the phenotype and subphenotype of eating behavior in people with obesity candidated for bariatric surgery. The relationship with their previous comorbidity and also the psychological symptoms related to anxiety and depression, as well comparing pre and post-surgical eating behavior. The methodology was designed as a descriptive transversal study, and the sample was of 211 adults that were evaluated between December 2022 and August 2023. The variables that we used was the eating behavior phenotype scale that was used to evaluate the eating dysregulation and characterize subphenotypes like disorganized, hedonic, compulsive, hyperphagic, and pecking emotional. We also use the Beck test for depression and the Hamilton test for anxiety. A post-operative assessment of eating behavior was performed in 30 participants. Was performed in 30 participants. This is the typical pre-surgical psychological assessment that we do in our clinic that is guided by the psychologist. So the first thing is the clinical psychological interview that is done in every single patient. And we also then use the different tests. The psychological test that we use is for anxiety and the other one for depression. And we also the FK. And finally, with this evaluation, we get the bariatric psychodiagnosis. So these are the eating behaviors that make of divided in 5 subphenotypes that you can see: the hedonics, compulsive, picking, and hyperphagic. And on the right side of the screen, you can see all the questionnaire or the questionnaire that we use to classify the different phenotypes. This is the score of feeding behavior type scale that we got after evaluate all the patients. And you can see here the total, and we can divide it in low, medium, and high according to the score. On the right side, you can see the value that we gave to each of the question, or how we get the value of each subphenotype. These are the characteristics of this subphenotype, or the scale of subphenotype. As I mentioned before, we have the disorganized that is, you can see the characteristic of each of them. Then the hedonic compulsive, that is rapid and excessive eating of food in short period of time. The hyperphagic, consumption of excessive portion of more than one portion in a single meal. And the last one, the emotional peaking, that is eating triggered by negative emotion that you can see here. So this slide shows how we did the data analysis of all this information. So you can see the different tests that we used. So where were the pre-surgical results? This is the example of the 211 patients. 70% were women and almost 30% were men. So the BMI, the median was 42, the age 41, the Hamilton's anxiety test was 12.63. That means the minor anxiety disorder in this group of patients. Then the Beck's depression test was 10. That means a mild depression disorder. And finally, the EFCA, the eating behavior, was 45.9, and that was a medium high level of disorder. And this was a different level of disorder that we found in this our group. And you can see in the middle, you can see here the level of the different phenotype in this group of patients. We also correlate this with some comorbidity like diabetes, and you can see that patient with type 2 diabetes has a higher EFCA score than non-diabetic patients. And then we are going to compare this result with the result of surgery. These are the prior slide showed the total EFCA score, and here you can see when we divide the different phenotype with type 2 diabetes, and they have had significant high score for compulsive intake of food. The same thing happened with hypertension. There is a correlation, but there is no difference in the difference score from non-hypertensive patients with hypertensive patients. Where were the post-surgical results and how we evaluate this result after surgery? Just to remember that we have 30 patients in this group. I know that it's a short number of patients, but this was a short time of post-operative time. That you can say that it was 118 days, so almost 4 months. The mean age was 39 in this group. There were 29 gastric sleeve and 2 bypass. The mean pre-surgical BMI was 42, and the mean reduction was 8.48 kilograms, and the BMI down low to 33 in the postoperative time. And after surgery, all EFCA score values were significantly reduced after surgery. In addition, a significant decrease in metabolic parameters was detected in glycemia. These are the results of BMI and weight after surgery, and as the postoperative assessment weight decreased, as I mentioned before, a mean of 23 kilograms, and the BMI was reduced by an average of 8.3 units. There was a significant reduction in blood glucose level, triglyceride level at the post-surgical assessment, where HbA1c was no different. These are the results of the EFCA score. You can see here the total, how decreased. There was a significant reduction, and also in all the different subphenotype of eating disorders. In conclusion, there is a strong postoperative improvement in patients after bariatric surgery. Type 2 diabetes patients show higher dysregulation, especially convulsive and hyperphagic intake. Depression, anxiety relate to emotional hedonic intake, and BMI correlate with hedonic hyperphagic intake, supporting target behavior following the EFCA monitoring. And this is the last slide. Eating dysregulation and associated with psychopathological condition can increase the risk of excessive caloric intake. We show that. And detecting this disorder in the pre-surgical phase will allow for timely intervention to prevent or reduce the recurrence of weight regain. An interdisciplinary approach is necessary to ensure that surgical treatment of obesity is not insufficient. Thank you for your attention, and I invite all of you next year to our meeting to see the other side of the Andes. Thank you.
I want to thank everybody for supporting this very interesting session. And I'd like to thank the moderators and also the audience. So thank you very much and enjoy the rest of the meeting.